Good afternoon. Today we'll be discussing prediction of survival and frailty in patients with metastatic tumors. My name is Ilya Laufer. I work at Memorial Sloan Kettering Cancer Center in New York City.
This is Joe Schwab from Mass General in Boston.
Dan Sciubba, Neurosurgery, Johns Hopkins, Baltimore.
So decisions for treatment for patients with metastatic tumors in the spine can be fairly complex and require consideration of multiple factors. We've previously discussed some of the indications for surgery and surgical methods. Today we'll focus on things that can really affect our decision about whether we should or shouldn't take the patient to surgery once we make that decision. One of the key factors, of course, is prediction of survival and their risk profile in the perioperative period. Both Joe and Dan have done a lot of work in this regard. I think maybe the first question for Dan is, Dan, do you think that we're actually good at predicting survival?
Yeah, it's a great question. We seem to use a lot of resources to try to predict survival, and no one's really good at it. We have at our disposal medical oncologists, we have population studies, and we have surgeons who get a judgment factor, but what we're finding is that we're very poor at predicting. And this is important because we often are exposing patients to large interventions. They want to see if this large intervention, which is often at a cost to them, physically or emotionally, will eventually come back and they'll be able to reap the rewards of that intervention. If they don't live long enough, it becomes a harder discussion with the patient. So we'd like to have some better or more accurate ways to be able to give them the full picture, to give them the reality of that. And that's what we've been trying to do with some of our research.
Thanks, Dan. Joe, and you've done a lot of work to actually improve our ability to predict survival in patients undergoing surgery. What was the impetus for that, and what did you come up with?
Well, as Dan said, I was concerned when you look at the studies that have looked at prediction, we're really very poor. And so it does require us to use an algorithm, some type of an algorithm, to help us, sort of a decision support. And the algorithms that were out there, we didn't think that were all that accurate. And we started to use some linear regression models to develop nomograms, which we liked, but still they weren't perfect. And so we started to move towards using machine learning algorithms. And now we've been using several different types of machine learning algorithms that allow us to predict better and more accurately. And then have subsequently created an app in order to facilitate doctors using it.
And what are the considerations that are taken into account when predicting survival?
Well, I think there are lots of things that are seemingly obvious. So age, for instance, the histology, very important. But there are some other things that we've found that are predictive, such as their albumin levels, or for instance their neutrophil to lymphocyte ratio. There are several individual parameters that turn out to be very, very important and predictive. And so as we continue to study this, we're gaining new insights into what parameters are predictive. And as these models improve, or as our parameters improve, our models improve.
And I think another question around this app is what has been done to validate it?
Well, that's probably one of the most important things, is to validate your algorithm with an independent sample. And as you know, and as Dan knows, we've worked with both of you in your institutions to help validate these algorithms. And I think that's an important step, but we're going to have to start to branch out into actually internationally to try to validate these models outside of our country.
Dan, and you've done a lot of work in frailty prediction. Do you mind speaking about what that is and how that can be used?
Yes, so what often happens in the setting of patients with cancer of any type, but definitely with patients with spine tumors, is that we talk about survival. And then we talk about quality of life in general for spine patients that are not cancer. And so really the issue that comes to light very quickly is that survival is not something that defines someone completely and how long they're going to live. It actually is the quality of living. And one big component of that in the cancer population is this idea of frailty. So as people get sicker, their quality of life declines, and that also has a direct impact on our interventions. So if someone is more frail, they're more likely to get more post-op complications, or they're more likely to not handle chemotherapy as easily. And so what we find is you have to have multiple dimensions to the counseling. One might be survival, one might be how robust the patient is. And if they're not robust, we can potentially push them over an edge where they regret the decisions that we've involved them in. And what we do is, as Joe alluded to, there are a number of factors of frailty that have been looked in the literature in other areas of medicine. And what we're finding is we're trying to identify some core attributes that are predictive. And what we've started to find is that there are some pretty robust attributes in each series of patients. So we look at a number of patients and then we say this actually jumps out at us. The fact of the matter is, as Joe alluded to, that has to become a smart tool. So what happens is as we keep getting better and more patients, we have to refine it. And what would be ideal is in the future to have a set of criteria that are very predictive across all populations, across all cultures, across all countries. And then I think we'd have a little bit more of an idea when we see patients that we're talking the same language and actually takes a lot of the individual judgment out of it. And we can actually sit there and give patients not a score, but some assistive judgmental or assistive decision-making capacity to help us with these very tough decisions. But frailty is going to be a key part of that.
And while we don't have an app for frailty yet, we do have an app for survival prediction. And where can that be found, Joe?
It's sorg-ai.com.
And how would people use that in their decision making? So a surgeon downloads the app. What do they need to actually use the app?
Well, you can you can access the website with your smartphone, or you can go to a computer and access it, and then you just input the parameters. And once you've placed the parameters in, you will get a prediction. Prediction of 30-day survival, prediction of 1-year survival. It will also tell you which parameters were important for that individual patient. So not only do you get a prediction model, but it'll tell you this parameter was more important in this patient and less important in another patient. And so I think it gives you very tangible explanations as to why that prediction was made.
And so how can physicians use that number to make that decision? I think that's probably the crucial question.
Yeah, I think, again, so when you look at these predictions, nothing can tell the future. So this is not there's no guarantee. It's like a weather forecast. So for instance, if the weatherman says it's an 80% chance of rain tomorrow, and then tomorrow it doesn't rain, was he wrong? No, he wasn't. What he was saying was that in their model, if their model is run 100 times, 80 out of 100 times it would rain. 20 out of 100 it wouldn't rain, and that's the same thing you have to approach with when you're getting these prediction models. It doesn't make a decision for you. It gives you sound data to speak to a patient about. If someone you're predicting that they have a 10% chance of surviving 3 months, that doesn't mean they're going to die. What it means is this patient is frail, they're sick, they're probably not going to live very long. Perhaps you don't want to consider a surgery. But it doesn't make that decision for you or the patient. It just gives you solid information upon which to make your decision.
Maybe the last question for Dan. So let's say we use that app and we had a 50% chance of surviving 3 months and 30% chance of surviving 6 months and 30% risk of postoperative complications. What kind of conversation would you have with the patient?
Some of those numbers might, as Joe said, not make much sense to a patient. So what happens is, right now the discussion is very hard. Do we do surgery? Do we not? Where is this person in their life? Where are they with their family? But numbers are very liberating. So if you tell a patient, hey, there's a high chance, and actually it's 9 out of 10 times, this is going to be the right thing, patients and their families, regardless of what ends up happening in the future, probably have some peace of mind that they're doing the right thing for themselves or the right thing for others. In really tough cases, it's always going to be tough. But sometimes these algorithms can give us a pretty clear direction, and that gives everybody more peace of mind as these end-of-life decisions or very, very complicated medical decisions are made. People want peace of mind. This is just one aspect to color it a little bit more with some numerical data, rather than saying, I don't have any idea, or I think it's going to work out. We actually say, this is your timeline. Let's be prudent about this. And although it's scary, I think if I were a patient in that situation, I would appreciate some of that detail to help me make that decision with me and my family.
Thank you, Joe and Dan. Hopefully this information will provide physicians with some useful instruments for making decisions about how to treat their patients and facilitate decisions for the patients and the families.